Okay. Good morning. Thank you, Mr. Chairman. Yes, I will try in a short way to talk about which are the possibilities. I saw that there is a lot of interest also here in the Pan-Arab Society about this issue, and actually it's an issue in most of the Occidental countries, how to manage pediatric craniopharyngioma with a radical approach or a more conservative treatment. And there has been a discussion of many years, of decades, as you know. Historically, we have become able to resect more and more tumor with time along the decades. So we are now able, with technology, with improving of the surgical technique also, and improving of the imaging modalities, to remove this tumor completely in many cases. But still, this number of cases improved, but arrives up to 75, maybe 80% of the cases, 90% in serious based on surgical impression. Still, the price of this kind of aggressive approach being a high morbidity. We know that we have the mortality of aggressive surgical approach, which is up to 3%. We have a morbidity up to 35%. We have endocrinological problems in up to 100%, which can appear or even worsen after surgery. And also, we have not to forget that we have recurrences in up to 25% of the cases. The second kind of approach that has been historically done in this kind of patients is a limited surgery joint with the radiotherapy, which has had statistically similar results in terms of control of the disease, a similar risk of hypothalamic dysfunction, but a significantly lower mortality and surgical morbidity. So where should this pendulum, as we call this kind of way to go from aggressive to conservative and then back to aggressive, go? The ideal road to me should be to decompress, obviously, the optical hypothalamic structure, to reestablish a correct CSF circulation and avoid as much as possible the dissection of the tumor from the hypothalamic structure, which increases the mortality and the morbidity of these patients. With this objective in mind, we went to compare our past policies between 90 and 2002 children, which was to extend radical surgery in all the cases, eventually adding radiotherapy when incomplete resection was achieved, with a second kind of approach that we started in the beginning of 2000 up to the 2009, the number of patients that we consider, because we wanted to have a follow-up of at least 5 years. Since the recent years and the second decade we considered in our options, apart from traditional surgery, we know that there has been a lot of improvement in the endoscopic endonasal transsphenoidal approach, and we will have a talk about this. We have the possibility to treat this kind of patients, especially those with cystic lesions with the interferon, intracystic interferon. And we have the aid of ventricular endoscopy, and radiotherapy has changed a lot, being a conformal radiotherapy. So a lot of things more compared with the past that we can use in this kind of patients. So we went to compare 52 patients that was the series with an aggressive approach with 38 patients, which is the series of patients that came over in the second period that we changed our strategy. You see the kind of symptom, the craniopharyngioma site, and also the kind of typical appearance was very similar among the two groups. The thing that changed is the possibility we had to add both intracystic therapy or endoscopic transsphenoidal surgery or even transventricular endoscopy. So how were the dates and which were the results of this kind of studies? With a follow-up more than 5 years, there were 40 patients in the first group, and compared with this second group, what we achieved is that joining total and subtotal resection, the kind of percentage was very similar among the two groups. We had some more kind of recurrence, but not statistically significant in the more multimodality approach, I would say. Just change it a little. What changed a lot was the morbidity. And actually, as you have seen in the previous slide, certainly the morbidity in the second group was much inferior compared with the first group, especially for hormonal deficit. It was significantly changed. The surgical approach for intracellular craniopharyngioma was substantially endoscopic transsphenoidal in all cases. The only kind of complication that we will speak about in the talk about endonasal surgery was the presence of CSF fistula in 3 of these patients. We also had the supracellular approach, which actually we treated more traditionally, but you see the number of complications was significantly higher, and especially we had 15% of hypothalamic disturbance that appeared after surgery. So the main thing was the difference, especially in the endocrinological morbidity of the transsphenoidal approach compared with this kind of 2 different operations that we performed in this surgery. We also used the interferon, intracystic interferon. Actually, our series was in details of 17 patients, which are joined in these patients with at least 5 years of follow-up. And both as first indication as well as for recurrences, around 50% of the patients are stable in time, are good responders, and still we didn't need to operate this kind of children. This also means that these children grow up in a good endocrinological condition, in a good hormonal status, and so it came over their growth much better than what we had as a result with a more aggressive approach that we had performed in the years before. This is a very important thing to us. This is simply a few notes about how do we use the intracatheter positioning. This is very well known. Most of the cases in our setup are done with the use of the endoscopy. A low percentage of cases done with an open craniotomic approach that was the first proposed originally by the Brazilian groups who had started this kind of process and involved us in multi-center international studies. What about the role of ventricular endoscopies? Another thing that we can use now that we actually didn't consider in the past. We know that a great majority of craniopharyngiomas in children have a cystic component. And when this kind of component is multiloculated and extended inside the ventricles, ventricular endoscopy might have a role in this kind of patients. We see this experience that we performed in these patients, especially with the objective to decompress the tumor and especially the hypothalamic structures. What about the outcome? The outcome of this second group, the 30 cases that had a 5 years follow-up, was significantly improved, especially in terms of both hormonal condition and visual condition. We had 2 cases with a poor outcome that were both giant craniopharyngiomas. I will just show the case, one of these cases, to conclude my presentation about this. This was a case of an 80-year-old guy with this kind of picture at the time of diagnosis. These patients had a clinical history quite common with other patients with more neurological deficit. At the time of surgery, it was really cyst after cyst possible to remove this kind of tumor. So we were attracted by mermaids. You see that the postoperative MRI shows a complete removal. So it was not intended, but at the end was a complete removal. Then these patients started to have problems with CSF circulation. He needed a VP shunt. He had a third cranial nerve palsy with a worsening of the hemiparesis. He had a complete hormonal replacement. So this is after 10 months. What happened? A sudden regrowth of multiple cysts in spite of a complete, even if unintended, tumor removal. So we went to a second surgery. Again, I will not show the video. It's just a concept that is important to me. But just after surgery, he already began to worsen. He began to be class 3, which, as you see from the classification, means serious visual compromise. It was starting to be partially dependent with hemiparesis worsening. And he also had a femoral thrombosis. 2 years later, this is the new appearance of new cysts with neurological worsening. In this case, parents refused major surgery. We proposed ventricular endoscopy to open the different cysts one each other. Always in these cases, try to do this kind of surgery with the help of neuronavigation because it might be very difficult to proceed. But again, it's still the concept that is important to me. This led to an improvement of neurological conditions. Thanks to this surgery, we were able to open one cyst to the other and get one environment. 1 year later, with stable clinical conditions. But then, 1.5 years later, again, recurrences of cysts. This happened after a first approach as an aggressive approach, even if unintended, as I told you. He was under oral anticoagulant because of the thrombosis and had an hemorrhage, as you can see, inside one of the multiple cysts that recurred. This is the MRI at those times. Again, we used ventricular endoscopy to open and remove the blood inside of the cyst. So what just I wanted to say is, yes, I know that it's very well known that giant craniopharyngiomas might go worse, but this is just one example of many cases, even if not giant, that even with a total removal can go to multiple recurrences with a bad neurological and endocrinological status. So the algorithm that we are actually using is changed a lot. We changed a lot of first-line treatment. As you have seen, if you have a simple cystic craniopharyngioma in a very small guy, our first line of treatment will be just intracystic interferon as first treatment to try to maintain the patient in a good hormonal condition. If it's a tumor, especially that is attached to the hypothalamic structure and infiltrating, then we go for a partial removal plus conformal radiotherapy as treatment of choice. With multiple cysts, we use ventricular endoscopy to open the multiple cysts, and eventually there is a nodular component. We go for conformal radiotherapy, and only when we can have a safe resection and separation of the tumor from the surrounding structure, limiting our damage, not avoiding, limiting our damage to the hypothalamic structure, we go for a more extensive surgery. Thank you very much, and thank you for your questions.
Thank you. Thank you, Dr. Tamburrini.